Hi, my name is Dr. Neil Iyengar, and I'm a medical oncologist and physician scientist at Memorial Sloan Kettering Cancer Center in New York. We'll be soon moving to Emory University in Atlanta. I'd like to discuss my poster, and this is our multicenter phase 1 trial looking at exercise therapy during first-line endocrine therapy plus CDK4/6 inhibition in hormone receptor positive metastatic breast cancer. So just to lay some background points here, first important to note here that we have large observational data sets which indicate an association between reduced breast cancer-specific mortality and physical activity. Now, there is a lot of heterogeneity to this data, and most of the observational data includes patients with early-stage breast cancer as opposed to metastatic breast cancer. So this space is an area of need for investigation. However, we don't know the appropriate dose of exercise in the metastatic setting. Most of the exercise guidelines have been developed for cancer survivors or people with early-stage cancer. So we set off to do a dose-finding study where we would test initially 4 different doses of exercise, and that is seen here, starting at 90 minutes per week of treadmill walking, 150 minutes per week, 225 minutes per week, and 300 minutes per week. We found that patients were doing so well on these dose levels that we amended the protocol halfway through to add an even higher dose, a 5th dose level, of 375 minutes per week. Now, just a note on the exercise intervention, these were personalized tele-exercise, we call it, intervention, whereby each patient who participated received a treadmill that was shipped to their home. And it was equipped with a lifestyle monitoring kit. This means that they received an iPad so that they could undergo supervised exercise sessions in their home that were prescribed by our exercise physiologists. They also had a Withings watch, a body composition scale, a sleep pad, and a heart rate monitor so we could monitor multiple different lifestyle parameters and prescribe individualized exercise based on which dosing cohort patients were allocated to. So down here we have our patient characteristics. We enrolled 54 patients with a median age of 53. All patients had hormone receptor positive metastatic breast cancer, receiving first-line treatment with endocrine therapy plus a CDK4/6 inhibitor. Just a note on the types of, or the cancer burden here. We see that about 22% of patients had de novo metastasis, 43% had visceral metastasis, and the majority of patients, close to 70%, had one side of metastatic disease. This is, of course, hormone receptor positive first-line setting here, so we typically anticipate a lower volume of disease. Most patients received an aromatase inhibitor, with about 20% getting fulvestrant, and all patients, or nearly all patients, received a CDK4/6 inhibitor, and you can see the specific types here, with palbociclib being the most common. So in terms of defining the primary endpoint, which was feasibility, we used a metric that is adapted from pharmacologic trials, specifically relative dose intensity, which we adapted and call relative exercise dose intensity, or the READY score. And essentially, we were looking for a relative exercise dose intensity of 75% or greater, again, consistent with the benchmark used in drug development trials. What we found were a couple of dose levels that met the pre-specified threshold for feasibility. So you can see here that the READY in the 90 minutes per week group was 80%. In the 225 minutes per week, it was 82%. Whereas in the other cohorts, the 150, 300, and 375, the exercise dose intensity was below the threshold for feasibility. And you can see that graphically depicted here. In a very exploratory analysis, we looked at preliminary efficacy using the 1-year PFS rate by dose level. And what we found was the 1-year PFS rate was best for the 225-minute per week dose level. So ultimately, when selecting the recommended phase 2 dose, we found that 2 exercise dose levels were feasible, 90 minutes per week and 225 minutes per week. And we found in an exploratory secondary analysis that 1-year PFS rate was best for the 225-minute per week dose level. Given the feasibility and the promising efficacy data for the 225-minute per week dose level, this was selected as the recommended phase 2 dose, with a plan to move forward into phase 2 preliminary efficacy trials as the next step.